Jill, Maddie, Janet, Sabine. Oh, Lucille.
Oh, I'm sorry. I'm trying to catch you with the front. I'm like, what is this? My butt's on That was funny. And then I landed on that. I was hoping that water bottle was there. Just in case now I can use
I have polls for anybody who wants to check them out, see you after class. Have a great time with the awesome Dr. Brandon.
I'm taking coconut cookies. Why do we need that?
Maybe one of you guys is strong enough. Do you think you can push this?
Just saving the day today. Thank you. You're welcome.
Let's see if it works. For some reason the other battery isn't working. Can you guys hear me?
I can hear you, but not through.
Not through the mic. No, right? Do you know if this was working this morning? Did you guys have a class here in this room? Did you guys have a class in this room? Do you know if it's working?
Did Miss Lee mic'd up? Was Miss Lee? Dr. Parsi was mic'd up. Yeah.
Yeah, you were able to hear?
Yeah.
Someone's trying.
You got a channel reason.
The green light should come on though. It's not coming on. What put it on?
Is the battery good?
Yeah, so I changed the battery. There was another one there.
Is that battery good?
That didn't work. That's the one I just changed.
Hold on.
Can you guys hear with this one?
There we go.
Was it the other way around?
Put it in the wrong way.
That makes sense. Thank you. Can you guys hear me?
It's red.
No, it should be green. Can you guys hear me?
Let's try the other battery.
Yeah, put it the right way. No, that's the way it is.
No. Because see the holes? So
Yeah.
you want to put the big end?
Oh, you mean on the, okay, that side, yeah.
It was just green a second ago. It was just green. I saw it flip green.
That's okay, I'll just do it.
See, it flipped green.
That's not strong enough, I guess it's probably at the verge of dying. No, I don't think it's a loose contact.
It's probably just the battery. They probably got left on over break or something.
Absolutely. Yeah, no, this was actually wrong when I came in.
Yeah, that's probably what it is. They get left on and they just die.
Okay, guys. The batteries are not working on any of the microphones, so you just have to be super quiet to hear me. Unfortunately, can you guys hear me all the way at the back? Okay, loud enough? Okay, good. So we talked about neoplasia on Friday. We started with, definition, different terms like hyperplasia, hypertrophy, dysplasia. So we looked at a lot of different terminology. So what we're going to do today is finish up neoplasia, and then so that's the end of all your general pathology topics. So because for your Gen Path section exam, this is going to be on your section exam for Gen Path, okay? So that's next Monday. So neoplasia is going to be a part of that. And then we'll continue with soft tissue lesions after this is done. So when we talk about neoplasia, we talked about different characteristics of a neoplasm. So we talked about parenchyma, we talked about stroma, and then what features you need to look for, like invasive potential, metastatic potential, right? And then, so now we need to look at what are the things that are potentially, contributing factors, right? So what causes neoplasm? So you have different components for neoplasia. One is an environmental component, but the other one is a genetic component, right? So when you look at environmental component, what are the traditional risk factors that you guys are familiar with for a squamous cell carcinoma in the oral cavity? What are the two big risk factors that can cause cancer in the oral cavity? Smoking.
HPV.
HPV is on the rise recently, but traditionally it used to be alcohol, right? So tobacco and alcohol were two products that were traditionally associated with increased risk of oral cancer, right? But then the development of a tumor is just not dependent on tobacco and alcohol, because the other factors that can potentially, cause tumors. It could be sometimes the development of the tumor could be dictated by the age of the patient. So the risk for malignancies usually increases as the patient gets older, right? So a 70-year-old male has a higher risk of developing oral cancer compared to, a 20-year-old male. So with increased age, there's an increased risk of developing cancer. So age could be a factor. Diet, so the products that we eat, especially if you look at processed foods, there is some correlation with developing, malignancies because of processed foods. Meats that are smoked have also been associated with increased risk of cancers. So diet could play a role, okay? Geography, right? So where the patient comes from can have an impact on, what is the increased risk for a certain kind of disease. So for example, more patients die in US and Europe from breast cancer. Okay, if you look at basically some of the Asian countries, so if you look at Japan, more people die from stomach cancer. Okay, so geography, like if you look at African Americans in the United States, they die more commonly from liver disease, liver cancer. So it depends on the race, it depends on geography, it depends on the diet. It depends on genetics. It depends on occupational hazards. It could be or social habits like tobacco and alcohol use. Okay, so there's many things that play a role. So when we talk about neoplasia, basically you're saying that there's some kind of exposure to a carcinogen, right? What is a carcinogen? What does the word mean? Something that causes cancer, right? And what does carcinogenesis mean?
The making of cancer.
Yes, the mechanism behind how someone gets cancer is carcinogenesis, right? So carcinogen is actually the product that's responsible for causing cancer, and carcinogenesis is the mechanism behind it, okay, the pathogenesis. So there's three main classes of carcinogenic agents. So you have chemicals, you can have radiation, and then microbial organisms. Okay, so in radiation, what is the most common reason why you would think someone can get a malignancy, a cancer? Ultraviolet radiation, right? UV radiation is the more common reason why someone has an increased risk for developing malignancies. We'll talk about each of those briefly. Okay, so when we talk about you so much. Thank you.
You're welcome. I'll take these for recycling. Sorry to interrupt.
That's okay. Thank you.
Is it green?
We'll try. I haven't switched it on yet. Still, oh, it's green. Can you guys hear me? Can you guys hear me? No? Okay. How about now?
Yeah, I don't know how this thing works.
One time I came here and I lifted up the desk and like the sweater was sitting on the desk. Yes, I mean it's like it all.
It's connected to that. Can I borrow that pen?
I have a screwdriver in my car, but
That's okay.
We have our tiny ones in our
I'll
cabinet.
just speak loud. That's okay. Let's not waste time.
sorry, Dr. Grundy.
No worries. Thank you. Okay. Let's get back. Okay, so when we talk about different carcinogens, so what were the three categories of carcinogens that we were looking at? Chemical, radiation, and microbial products, right? Okay, so when we talk about chemical carcinogens, you can have some that are naturally occurring and then some that are, artificial, right? So if we look at, the natural plant and microbial products, you're basically looking at a product that's called aflatoxin. So this is basically something that grows from aspergillus, the microorganism, okay? And this is something that if a grain or a nut is not stored properly, then they can have, increase in the growth of aspergillus, okay? And then that can release this substance called aflatoxin, which can be associated with, development of malignancies, okay? Have you guys heard of betel nut? Okay, so there is a product called betel nut, and especially if you look at South Asian countries, okay, this is very prevalent in India, okay. So what they do is they take a betel leaf, and then they take this betel nut, either crushed betel nut or in whole, and then they place it on the betel leaf, and then they also use like calcium hydroxide, okay, slaked lime, and then they make like a coating of it on the betel leaf. And then sometimes they also use tobacco, okay, like so in a powdered form, okay, and then they place it along with this betel nut, and then they roll it into a quid, and then they chew. So unfortunately what happens is when they do this, it causes a condition called oral submucous fibrosis in the oral cavity. So what happens is if you look on the inside of their cheeks, these patients, or the inside of their lips, it becomes really thick, and it becomes very taut, just like you guys remember scleroderma? When we looked at scleroderma, how we said this increased collagen production and everything becomes really firm, and they have almost like a mask, like expressionless face. So same thing happens inside the mouth. The kind of changes you see is it's a very thick mucosal surface that you're going to feel, and it's going to be pale, okay, in color, and it has like a whitish kind of appearance to it, and if you touch it, it's almost going to feel like a hard, board-like surface, Okay, so the problem with oral submucous fibrosis, unfortunately, is it increases the risk of oral squamous cell carcinoma significantly. So patients with that disease process end up getting oral cancer. Okay, and there's a high incidence of oral cancer in India. And one of the products that's responsible for this, unfortunately, is betel nut. Okay, so it could be something that could come from a plant or a microbial product, a chemical, a carcinogen, or it could be, artificially used, right? So if they use insecticides, fungicides, nitrosamines, asbestos, there's many things that have been linked to causing malignancies. So nitrosamines, which product do you think is can produce nitrosamines? What is it used for? Nitrates or nitrites?
Fertilizer.
Meat products.
Preservative, right? So they're used as preservatives, and that's one of the things. That's why I said something that's cured, the meat, and that's preserved, and when they char it, it increases their risk for malignancies much more than other kinds of products. So there's a huge list. You guys don't need to memorize this, but you can see how different products are associated with different kinds of malignancies. So if you see here, I can make this work. So you have asbestos, that's something we always see advertisements on TV, right? Have you been exposed to asbestos? Please contact this lawyer, because they're all, this is something that we commonly end up, listening to. What do they end up getting is mesothelioma. Okay, is one of the cancers that they advertise. Okay, so you can get lung cancers, esophageal cancers, colon cancers from benzene products, which is basically seen in light oil, right? It's seen in paint, in dry cleaning products, in adhesives. All of these can be associated with acute myeloid leukemia. So if you look at this list of products and what kind of malignancies they're associated with and where do you typically find these products, you can see that there's such a correlation, between a chemical and its ability to cause malignancy. So the next source for development of malignancies is radiation, right? So you have different sources of radiation. So you have UV radiation, which is the more common source. And what is the most common skin cancer that's seen secondary to UV radiation? Basal cell carcinoma, right? So basal cell carcinoma is the most common skin cancer that's associated with exposure to UV light. Okay, so you always tell a patient who is light skinned, right, and who has increased risk of like sunburns, okay, to wear like a sun hat, with basically to prevent direct exposure to the sun, right? And UV radiation can also cause malignancies of the lip. Okay, so you can get squamous cell carcinoma of the lip from UV radiation. So always recommend your patients to wear, use a lip balm, with SPF, right? So you want at least, a 35 or 50 SPF in order to protect their lips. Otherwise, you can get changes that are precancerous that can eventually turn into a malignancy. Okay, so UV radiation is a big source. It could be from X-rays. Okay, obviously this is not something that this is not very common, right? Nuclear fission material, people who deal with it, they have to be more worried about this risk factor. Okay, so but what impact does it have is it can cause genetic changes, right? It can affect the chromosomes, which can in turn cause a cancer to form. Okay, so how about microbial? Okay, so now we talked about chemicals, we talked about radiation. So the last group was microbial products, right? These are environmental reasons why you can get cancers. So with microbial products, you can have a viral or you can have bacterial or a fungal reason why you see cancer to form, right? The most common DNA viruses that you need to be concerned about are these here. Okay, so HPV associated oropharyngeal cancers are on the rise, okay, in the US. So when you compare to like 20 years ago to now, there's almost a 200% increase in the number of cases of HPV associated oropharyngeal cancers. Okay, good example for that for someone with oropharyngeal cancer is what's his name, Douglas. What's his first name? He's an actor.
Michael
Michael Douglas. Okay, so Michael Douglas actually had a malignancy of his throat. Okay, and it was actually secondary to HPV. So this is, and he brought about a lot of awareness. He talked about it quite a bit, about the correlation between HPV cancers and oropharyngeal. And it's important to know that because HPV associated cancers, they actually respond better to treatment. Okay, so when they get treated with radiation therapy, the prognosis is really good. So if they do end up getting an oropharyngeal cancer, it's probably better if it's HPV associated because they have much better prognosis, right? So you guys need to know the difference between oral cavity and oropharynx, right? Where does oropharynx begin? Back. What part of the back of the mouth?
The oropharynx. Past the soft palate.
Okay, so it's your soft palate area, the uvula, the tonsillar area, and behind your circumvallate papillae on the tongue, so your base of the tongue, right? That's all oropharynx. So if you saw a malignancy in the anterior part of the mouth, the oral cavity, so the dorsal tongue or lateral tongue or floor of the mouth, right? So if they are infected with HPV, it doesn't mean anything, right? It doesn't have any impact for the patient treatment-wise. So when they talk about oral and oropharyngeal cancers and being affected by HPV, you have to know the difference. The one that's most significant for the patient treatment-wise is an HPV positive oropharyngeal cancer, not oral cancer. There's a difference. Unfortunately, in the literature, those two terms are used synonymously, and it gets really confusing. Okay, so HPV is something you have to be familiar with, and there's also vaccination now, right, for both men and women, right? So boys and girls are both recommended to get vaccinated for HPV. So you can start vaccination around 11 to 12 years of age for both the sexes. Okay, it is important that both get vaccinated, not just women. Unfortunately, because for a woman to develop HPV lesions, the exposure, it takes more exposures to the virus in order to develop the lesion. For a man, it actually takes less exposure. Okay, so number of times that they get exposed to the virus is actually lesser in order to develop changes in the body for a man compared to a woman, right? So that's why the recommendation is both should get vaccinated. Okay, because they become carriers for the disease, men. Okay. Then you have Kaposi sarcoma virus, which can cause Kaposi sarcoma. That's a more common malignancy that's associated with this. It's a type of herpes virus. You can have hepatitis B virus, can eventually cause hepatocellular carcinoma. And then you have EBV virus, right? So Epstein-Barr virus, it's associated with a lot of malignancies. But all of these are DNA viruses. So that means what happens is the virus, once a patient gets infected with this virus, it integrates into the host DNA. This virus, and that's how they bring about changes. Okay, then you have RNA viruses. So there's a virus called HTLV1 that causes this disease, T-cell leukemia and lymphoma. Then you have bacteria that can cause malignancies. Most common bacteria is H. pylori, Helicobacter pylori, right? And this is responsible for cancers in the stomach. Okay. So it's critical. Whenever you look at malignancies, you have to try and figure out what is the potential carcinogen that's causing this malignancy, right? Is it a chemical carcinogen? Is it a microbial product? Is it radiation that's responsible for it? So is there an environmental cause, or is there a genetic reason behind this? Okay. We won't worry about this one. This is not too critical for you guys, the reproductive history. Okay. So then sometimes you can have acquired predisposing conditions. So if someone has a condition or a disease where they constantly have inflammation, chronic inflammation, or if they're immune deficient, okay, that can also increase their risk for developing a malignancy. Okay, or if they had a previous malignancy in an area, for that patient to develop another malignancy, that risk is higher. Okay. Okay, so let's see. So these are some examples of chronic inflammatory conditions and the kind of cancers that can develop. So one of the things that you should look at is this one. So if you look at patients with acid reflux, right? So they have what's called reflux esophagitis. So those patients, when they have acid reflux, over a period of time, if left untreated, it can transform into a condition called Barrett's esophagus. Okay, so there's transformation of the lining from one type to another subtype here. There's metaplasia. So when patients have Barrett's esophagus, they can actually develop esophageal cancers. Okay, so acid reflux disease, if left untreated, can potentially, be a precursor to a malignancy. Okay, so that's critical. The other thing for us that's important is, from a dental perspective, is Sjogren's syndrome, right? So if a patient has Sjogren's syndrome, do you guys know what Sjogren's syndrome is? Yeah. Okay, so Sjogren's syndrome, it's an autoimmune disease, okay? It basically affects different structures in the body. It can affect salivary glands, it can affect the eyes, and it's usually can be associated with another autoimmune disease. So if someone has Sjogren's syndrome, they could have like rheumatoid arthritis in association with that. So clinically, what these patients end up having in Sjogren's syndrome is dryness of the eyes and dryness of the mouth. So that's the common complaint: dry eyes and dry mouth. Okay, so it's basically a disease that affects the salivary glands, in the oral cavity, right? So when it does that, if again left untreated, and if it's a chronic inflammation that persists, then these patients can end up with a lymphoma in the salivary glands, okay, a malt lymphoma. So, but these are chronic inflammatory states. Okay, so then you have the genetic component. So whenever you look at neoplasia, and then you start looking at what are the risk factors for someone to develop a neoplasm or a malignant neoplasm, you have environmental risk factors and you have a genetic component, right? When you look at environmental risk factors, there were three big classes that we looked at. One was radiation, the other one was chemical carcinogens, and then the other one is microorganisms, right? So three big categories. Then we looked at sometimes you can have an acquired environment where they can develop malignancies, like someone who has chronic inflammation can increase their risk for malignancy. Okay, so then you have the genetic component. So when you have a genetic component, it doesn't have to be independent of each other. So genetics, and environmental factors can can go together. So if someone smokes, for example, it can alter the genetic environment for the patient and then increase their risk of developing malignancy, right? So, or they could be because of certain mutations that happen in the body, without any risk of smoking or alcohol or other factors, a patient can still develop a malignancy. Does that make sense? I know it's a bit confusing. So whenever you're worried about someone, having a malignancy, you have to look at, is this an environmental risk factor that's responsible for it, or is it a genetic mutation that's responsible for it, right? So if it's or sometimes it could be a combination. So the environmental risk factor can actually cause genetic changes in the patient, which can in turn lead to a malignancy. So they don't have to be separate from each other. They can go hand in hand, right? So when we look at cancer genes, right? So you're basically, there's different terms that are used to describe genes that are responsible for malignancies, okay? So the ones that, so there's a term called oncogene, and there's another term called tumor suppressor gene, okay? So those are the two terms I want you to keep at the back of your mind, and then we'll talk about it, what it means. So oncogene and tumor suppressor gene. Okay, so cancer genes are basically genes that are affected by alterations, right? So whenever we talk about a malignancy and we talk about a cancer gene, we're basically saying that particular gene is affected by mutations, right? Responsible for causing the cancer. Okay, so how does a cancer gene acquire this mutation? How does it undergo changes? It could be because it's exposed to an environmental agent like a chemical, radiation, or microbial product, or it can be spontaneous. So patient don't have to smoke, drink, be exposed to the virus? Nothing. They can just have a spontaneous mutation in one of these genes, and then that can cause cancer for them, right? So sometimes patients come and tell you, like, I never smoked, I never used any kind of drugs, I never drank alcohol, but they still have, a malignancy in their mouth or in, other part of their body. Why? Because you can have a spontaneous mutation in a cancer gene, okay? Or it could be inherited. So there's some conditions that can actually are inherited conditions, right? So from mom to daughter, right? And in the germ line, you can actually pass this, genetic mutation that again increases their risk for malignancy. Does that make sense? So whenever you look at neoplasia, you have to try and figure out, what is it that's responsible for it? Is this have a genetic component to it, or it's purely environmental, or is it a combination? Okay. So we talked about, I said, remember these terms, right? So when you look at cancer genes, we have 4 classes of genes. You have oncogenes, tumor suppressor genes. These are your big ones that you'll always hear in literature. Then you have genes that regulate apoptosis. Do you guys know what apoptosis means? What does apoptosis mean? It's programmed cell death, right? So cells in our body are programmed to die at a certain time, right? So, and then you get new cells. So it regenerates. So that's called apoptosis. So there are some cells that actually, there are some genes that are responsible for regulating this programmed cell death or apoptosis. What do you think, if the cells don't die, what do you think is going to happen? So if that apoptosis is affected, right? So technically they're supposed to basically die every few weeks or every day, whatever with the time frame that you're looking at. But instead of doing that, they just survive. What happens? Yeah, so you've got more cells now, more cells that are living past their time, right? And they're mutated cells. So this is not good. So you have increased proliferation of cells here, right? Because they're not dying at the time that they're supposed to die. Okay? And you get abnormal cells that are proliferating. So what does that lead to? When you have an increased proliferation of abnormal cells that are not, it leads to a neoplasm. That's basically what that is. So genes that regulate apoptosis, right? And then you have genes that actually regulate interaction between tumor cells and host cells. Okay? So you have a tumor cell, and and then you have your own cells, right? The patient has his own normal host cells. Okay? So there are some genes that regulate this interaction between what a regular host cell and then the tumor cell, the cell that has undergone these mutations, right? So if those genes get affected, then again that's going to have an impact, right? So you have more cellular growth. Okay, so oncogenes are basically what do you think oncogenes do? Do they cause cancer or do they suppress cancer? Cause, right? Oncogene, it's a gene when mutated is responsible for causing cancer, right? So when you look at an oncogene, should it be is it going to be overexpressed or underexpressed? Okay, so in malignancies, they're overexpressed, right? Normally, they should be underexpressed. But if some mutation occurs in this oncogene, that can eventually cause overexpression of those genes and then cause the cancer. Okay? And then cause increased cell growth and stuff. Okay, how about tumor suppressor genes? Should you have more of those or less of those? More activity, right? So you want tumor suppressor genes to be more active. If they are not, and if there's a mutation that hinders, the activity of this tumor suppressor gene, what does it do?
Shuts off.
It shuts off the ability to actually suppress the tumor to grow, right? So it's going to end up causing a tumor to form, right? So you have oncogenes are overexpressed in a tumor. Tumor suppressor genes are underexpressed in a tumor. It should be the other way around, typically, in order to prevent a tumor to form. Does that make sense? Okay. Okay. This one basically just kind of show you schematically, what is it that you see, right? You have a normal cell, then you have a mutation in this normal cell. Why? Because the patient was exposed to a carcinogen. It could be a chemical carcinogen, it could be a microbial product, it could be UV radiation, something that caused, or it could just a spontaneous mutation, caused this normal cell, okay, and then caused it to get the stem cell-like properties. Then you get more mutations that happen here. Okay, they're called driver mutations. Driver mutations means they are the main mutations that are responsible for things to go bad. Okay, so what happens when you have more mutation in this, stem cell-like cell? You end up getting a neoplastic cell or a cancer cell, right? Then they undergo more mutations, and then it forms a mass or the tumor or the neoplasm, right? So in your cancer hallmarks is where the pathogenesis of the cancer cell arises. So that this is where, the cells that are supposed to die at a certain time don't die, right? So there's, genes that regulate apoptosis, they go haywire here. So all these cancer hallmarks are, and then you start seeing more blood vessels to form. So there's something called angiogenesis. All of those are considered hallmarks of cancer. When you have, apoptosis being inhibited, okay, when you have increased blood vessel formation, okay, those would be considered hallmarks of cancer. Okay, so this is basically what you're looking at. Someone with angiogenesis, so there's increase in vascularity of the tumor. There's self-sufficiency in growth signals, and then they are not, so you have signals that the body gets to inhibit growth, right? What happens is if the tumor becomes insensitive to that inhibitory signal, then it causes the tumor to grow. Okay, it can affect the metabolism of the cell itself. So that if that gets altered, that leads to cancer. It can evade apoptosis, so that means the cells don't die at the time that they're supposed to die, right? So that can lead to cancer. Then, so if they don't die, they become immortal, right? So when they become immortal, that makes it to multiply in number significantly. So there's a limitless potential to replicate. There's increased blood supply. Then they are able to invade and metastasize. And then once they start affecting different organ structures, they actually evade the immune surveillance system of the body, right? So that means the body is trying to send these immune cells to attack these cancer cells, but then they become mutated so much that the body cannot recognize the cells anymore. So it can evade the immune system. It almost makes it look like it's a normal host cell. Does that make sense? Okay, so if to kind of summarize that is you have a normal cell, okay? When there is a normal cell, what is it that can alter a normal cell? What things can alter it? What are the predisposing factors? Carcinogens can alter a normal cell, right? What kind of carcinogens can alter a normal cell? It can be chemical, it can be radiation, or it can be a microorganism, right? So the three things can have an impact on the normal cell, either because of the products they release or the chemical itself, right? Can do that. Okay. Or you can have a mutation in a gene independent of chemicals that can alter a normal cell, right? Remember we talked about oncogenes, tumor suppressor genes, genes regulating apoptosis, and genes controlling the tumor and host cells. So if there is mutation of the oncogene or tumor suppressor gene, that can also alter the normal cell. So once a normal cell gets altered, what do you think happens?
Its oncogenes are turned on, its tumor suppressor genes are turned off.
Okay, so typically that's something that's happening in the background, right? But this normal cell now transforms into a stem cell, almost like, a cell with a stem cell-like properties. Okay, now this cell, if it has more mutations happening, turns into a tumor cell, right? But once it turns into a tumor cell, now it has to grow, right? So in order for it to grow and not die once it turns into a tumor cell, it has to evade apoptosis. So that means it has to have certain mutations in order to prevent it from dying, right? Once that apoptotic gene gets mutated and the cells are not dying anymore, then they become immortal, right? Once they become immortal, what does that make that cell do? Start multiplying, right? Once it starts multiplying, it has to sustain in the human being, right? Once you have a tumor, it has to feed off something in order to sustain itself. What does it do? It feeds off the blood vessels, so you have more blood vessels forming, right? So that's your angiogenesis. But now, anytime you have something foreign in the body, what does the body try to do? fight it off. And how does it fight it off? With its immune system, right? So now what this tumor does is, now it changed into this tumor that is able to do all of these things, but then it changes its the outer layer or the wall. I'm just trying to simplify this. There's a lot more mechanism behind this, but what it does is it changes the property of the cells around it in a way that when the body's immune system is sending the immune cells and trying to attack this neoplastic cell, because it's changed its properties, now this body is recognizing this as just its own and not as foreign. That's how it evades the immune system. Does that make sense? So now, no matter how much immunity you have, and the cells are coming trying to take care of this, it's really not going to do anything. It's just going to keep multiplying, because now they're thinking this is just a normal process. Yes?
For what we were just talking about, the hallmarks of cancer, is it important to know the steps, or is it more important to know what happens?
What happens, yeah. You don't need to know the sequence of things. You need to know what happens in the process. But you should know the hallmarks of cancer. That's a critical thing to know. Okay, so this is your carcinogenesis. Okay, so what we talked about is the mechanism behind how cancers form in a very, very simplified form. I mean, there's like papers written on this about just oncogenes, tumor suppressor genes, microRNAs. There's just tons of information out there, and if you guys are interested, you should go ahead, read more about it. It's actually very fascinating. Okay. So when we have a cancer, right? Remember we talked about it last time. Is you have to grade cancers and you have to stage them. When we look at grading and staging is what they've realized is most effective to figure out what is the prognosis for that malignancy. Right? So staging of cancer is a better tool compared to grading. So what does grading mean? They look at the degree of differentiation, right? So you can have a low-grade tumor versus a high-grade tumor, or intermediate-grade tumor. So it can be just 2 grades, or it can be 4 grades. Depending on who is. I mean, there's criteria. There's something called NCCN guidelines. It's a comprehensive cancer network that gives guidelines for how do you grade these and how do you stage malignancies. And then they give you treatment guidelines on how they need to be treated, depending on what stage or grade. So that this is, but grading is not as critical to prognosis compared to staging. Right? So when you look at staging, there is something that we use for oral cancers. We're not going to worry about other malignancies, but for oral squamous cell carcinoma, we use a staging system called TNM. Okay, so T stands for tumor size. Okay, N stands for nodal involvement. So that's lymph nodes. And M stands for metastasis. Okay, so size of the lesion, ability to involve the lymph nodes, and then ability to metastasize. So that's your TNM staging, and that's an important thing to know. So here, so TNM staging is the size of the tumor, the primary tumor, N for regional lymph nodes, and M for metastasis. So this is the staging system that's used universally, to stage squamous cell carcinoma. So if you tell someone that this patient has a stage 2 cancer, they know what they're looking for. So it's a lesion with a certain size, and then if you say T2, N0, N0, basically you're saying that the tumor is of a certain size, there's no nodal involvement, and there's no metastatic involvement, right? N0, N0, 0, 0. So no nodes are involved, no, it didn't metastasize. If you say T2, N1, M0, what does that mean?
No metastasis.
So if I'm saying T2, right? Okay. And then I'm saying N1 and then N0. What does N0 mean? Is there metastasis? No. What does N1 mean? Is there a metastasis? Yes, N1 means there's actually nodal, there's metastasis to the nodes, lymph nodes. Okay, so there's nodal involvement. Okay, and T2 means, depending on the size of the tumor, you give T1, T2, T3. You don't need to know what measurements to look for, but you need to know what each of those words, letters mean. So how do you treat malignancies, right? So whenever you look at a malignancy, if it's a benign tumor, you can basically surgically, yes.
The staging here, it's not the same thing as like when they stage cancer, like stage 1, 2, and 3. That's not the same thing.
Yeah, it is the same thing. So when you say stage 1, right, basically you're saying it's a T1, N0, N0. So each stage has multiple, TNMs that can be associated with it, right? So typically stage 1s, the size of the tumor is less than 2 centimeters, right? So it's a T1, N0, N0. So they tend to be no lymph nodes involved, no metastasis. When we're saying stage 4, typically they tend to be a T3, N1, N1, or it could be T3, N1, N0, There's many different TNM subclassifications that fall under each stage. But we won't go into detail with that because that's an hour class that we can spend, just talking about different types of different stages. But the critical thing to know is why is the staging important, right? When we stage it, we're basically saying this is the prognosis for this patient. And the likelihood of this patient surviving at 5 years is determined by the staging, right? So if you're looking at oral squamous cell carcinoma at a stage 1, the likelihood of that patient surviving a stage 1 oral squamous cell carcinoma at 5 years is probably 70%. But if you're dealing with a stage 4, the likelihood is 30%, right? So that's a big difference in numbers. And that's why we always say with oral cancer, the biggest problem, what we encounter is lack of early diagnosis. Unfortunately, dentists, dental hygienists, other dental professionals see things in patients' mouth, tell them it's nothing, and then they don't do anything about it. There is never a nothing. If you see something, it could be just a linea alba, but it's not nothing, right? You have to document it. You have to have a plan, a follow-up plan for every lesion in a patient's mouth. It could be just a variation of normal. It could be abnormal, right? But you need to have a plan in place. You need to have documentation in place. So please don't ever say it's nothing. Even a fibroma is something, okay? Malignant tumors. When you look at malignant tumors, there's different ways that they can be treated. It could be just surgery alone, depending on the size of the lesion. They may have to do radiation therapy or chemotherapy, or sometimes they have to do combination, okay? But then if there's lymph node involvement, they do what's called neck dissection. So they actually take out the lymph nodes that are involved. Sometimes it could be a modified neck dissection, or it could be a radical neck dissection, again, depending on what pathway of lymph nodes are affected, right? So that's more from an oral surgeon and ENT head and neck perspective. So we'll just look at some epidemiology and then we'll take a break and then continue to soft tissue lesions. So if you look at epidemiology, so if you look at malignancies in general, right? So if you look at in the world, WHO basically says there's about 14 million new cases of cancer every year, okay? And about 8 million people die from cancers all over the world. That means about 22,000 people die from cancer every day. Okay, by the year 2035, look at how much it's jumping. From 14 million, it's supposed to go up to 24 million of cancer cases per year. Okay, in 2018, in the US, number of new cancer cases, and this is all types of cancer, not just oral cancer. Okay, 1.7 million. 600,000 people died from the disease in 2018. That's about 1,600 people dying from the disease every day, right? So this is critical. This is important stuff. And we play a role in diagnosis for these patients, right? A lot of times. And then if you look at men and women, 40 out of 100 men actually can develop cancer during lifetime. So the risk is a little higher for men compared to women. So women, it's 38. Okay. So after heart disease, cancer is considered to be the second most common thing that can kill people. Yes?
Is it important to know these numbers?
No, you don't have to know the statistics. But it's important to know what it means, so pay attention. You don't have to memorize these. So in 1995, if you look at cancer death rate, right, it went down by about 20% in men and 10% in women. And then the low death rates were related to lung, prostate, and colon. Okay, and then in women it was breast. predominantly. So this is just a map to show you, the number of cancer cases in different states. Okay, so in California, it's 178,000 new cases of cancer were diagnosed in 2018. And this is excluding basal cell and squamous cell skin cancers. The three most common skin cancers are basal cell carcinoma, squamous cell carcinoma, and melanoma. Basal cell is the most common. Second most common is squamous cell. Third most common is melanoma. But unfortunately, melanoma kills more people compared to basal and squamous cell, okay, on the skin. And these numbers that you're seeing here are not including basal and squamous cell carcinoma. Okay, this one you should know. This PDF, I'm going to, I don't know if I put it in your handout. If not, I'll upload it on the PowerPoint. Okay, so you need to know what are the leading sites of cancer. Okay, so in men, it's usually prostate, lung, colon, bladder, and melanoma of the skin. In women, it's actually breast, lung, colon, uterus, and thyroid. So the number of new cases you should know, and what causes death, right? In men, lung cancer is the most common reason why they die from the disease. In women, again, it's lung. So men and women both, leading cause of death is actually lung cancer. Okay, but incidence is prostate is higher in male and breast is higher in female. Okay, and you should know this one. This thing that I highlighted on the top with red, this is for oral cavity. Okay, so there's about, in the United States, it's about 50,000 new cases of cancer, oral cancer every year. You don't need to know men and women separation, just know the total number. Okay, and you don't need to know the site, tongue, mouth, pharynx. Just know about 50,000 cases of new oral cancers get diagnosed every year, out of which 10,000 patients die every year from oral cancer. Okay, you don't need to know these. It's just basically trends. Okay, so here, so this is what I want you to remember for trends in 5-year survival rates. This area that I highlighted for oral cavity. So in 1975, right, 77, there was about a 53% chance, okay, in all races. But look at the difference between Caucasians and African Americans, okay. In whites, the likelihood of surviving the disease by race is 70%, right? And look at blacks, it's 50%. So there's a significant discrepancy based on the race. If they get the same diagnosis of malignancy, Caucasians, unfortunately, the prognosis is better compared to blacks, okay, for the same diagnosis. So there's a difference based on race. Okay, and based on staging. So this is important, right? So if it's just a local disease, right? So if it's just localized to the oral cavity without any lymph node involvement or metastasis, look at the 5-year survival rate. It's 80% if it's just local involvement. But if there's distant metastasis, it goes down to 40%. Yes?
Is it really based on race, or is it actually based on availability to healthcare?
So that is in turn related to race. Because unfortunately what happens is the access to care is limited compared to Caucasians with blacks. So that in turn has an impact on the prognosis. So there's many factors. It's multifold, so it's not one thing that you can pinpoint and say this is what is responsible for such a decline in a 5-year survival rate. But yes, access to care is one of the things that plays a role. Okay. So you need to know again this 5-year survival rate, and that's why as providers we play a big role. If we are able to recognize this disease early on and be able to give this patient the necessary treatment that they deserve early on, then you can change these numbers, right? Why are these numbers not changing in the last 30 years? They're pretty much like this. They are at a standstill. It's because of that, because we are not doing what we're supposed to, right? We have to make an active effort to make sure diagnose these things, and then make sure that the patient gets the timely intervention that they need. Okay, because we can change these numbers significantly by doing that. So there is a patient component to the disease, but there's also a provider component to the disease. Don't just focus on teeth, or don't just focus on gingiva, right? There's more to the mouth than that. So it's a mirror of what goes on in a patient's body. So if a patient comes to you, take time to do a head and neck exam. Make sure you do a thorough intraoral exam. Look for areas that don't belong, right? If you don't know what it is, it's okay, right? That's when you ask for help, You send it to a specialist who can actually investigate further, But it's critical that you do your bit. Okay. And the number of patients that die from cigarette smoking, unfortunately, in 30 years and older, is 47% is from oral cancer. Okay. So these are just some recommendations. You don't need to memorize this. But then, how do you detect cancer in a patient who's asymptomatic, who is at an average risk? There's actually a really nice article, and I'll see if I can post it on your modules. It's from the Journal of American Dental Association, and it gives you guidelines on what you need to look for if you're a patient who comes in with a white lesion, with a red lesion. What are your steps that you need to follow? And then also it talks about there's another article that talks about adjunct tools. Have you guys heard of Visalite, Wellscope, and stuff? And Dr. Richards will probably talk to you about it. I'm not sure how much in depth she's going to go in, but there are some products that they market outside, and they say this, you should use this, it'll basically tell you if the patient has precancer or cancer. Please don't fall for that. That's a good adjunct, but it's not a primary diagnostic tool. Okay, your eyes are your best tool. Your intraoral and extraoral examination is your best tool. You can use that to support what you have seen, but do not use those as your primary diagnostic tool. Yes? Do you have questions? Okay. Okay, you guys can take a break. So we'll come back at 2:05, take a 10-minute break, and then we'll continue with the next topic.
Guys, I want to make a quick announcement. I just want to remind you guys about Friday night Vespers. I would like to do like a potluck style, like as usual. How many of you guys think that you could try to make it?
So we have a carcinogen
Raise
in
your
our body.
hands.
If that's the way it's like making a cancer, right?
Yeah,
And then
so
there's the
exposure to a carcinogen.
13. It's about, guys, I see right now about 13 hands.
Right?
That could increase or decrease.
And I get
Dr. Meredith
exposed to a
has like 2 months.
carcinogen, right? So the
I'm
carcinogen
also
could be
going to be
tobacco,
inviting some of the
alcohol,
seniors to come because I think
it
it
could
can
be
help them a
maybe
lot
I
too.
eat
So
some, smoky,
just prepare for about 3 more
something,
people when you
constipated
make
exposure.
bring
Or
something
I
extra.
went out into the sun and I like
Extra.
all whatever and radiation exposure. Or I'm direct
Oh, is anyone here with food
infection,
allergies?
So I'm a normal person and I got this exposure to
Lactose intolerant.
So what happens after that?
You don't care, we don't care. Carcinogen in your body, right?
I didn't like
Your cells are affected by this carcinogen, right?
It's
So
at
what happens is
6:30
the
everyone.
cell has to undergo changes, right? So basically normal. So for example, let's see. So if you have an intact cell, right? And then you basically now I came and I exposed it to high heat. This one, okay? This is my radiation. High heat, okay? So what do you think happens to my cell here? So it's going to undergo changes, right? It's not going to have same intact surface, So the cell now it starts figuring out that it has to deal with this change, okay? So then the cell, what it does is it starts undergoing alterations or modifications in its structure. Okay? So so it could be because of a mutation, or it could be because just the exposure to the material itself caused the membrane to get disrupted, maybe, right? So something is happening that basically
These are this one.
no, so these are genes that are responsible for causing changes in the cell. Okay? It's in the back background, basically. These things are happening in the background. So what happens is you have a normal cell. Now you have some kind of an exposure to a carcinogen. Now this normal cell is undergoing changes because of that exposure. Now when it undergoes changes, the kind of changes it undergoes is it'll basically, think to itself, okay, you know what, I have to stop dying because, if I die, then this is going to get worse, So it may undergo some modifications where it prevents the cell from dying, okay? And that gene that regulates apoptosis in the background, that gene may get mutated. So the chromosome, right, there can be some mutation, right? And then what happens is, so the
they
gene,
don't die?
so they can alter, but the genes, the genes usually don't. So basically you have a cell has genes in it, right? Now you have a mutation, you have a chemical exposure. Now this chemical exposure causes the cell to alter. And when it alters, that alteration could be at a genetic level, autosomal level, or it could just be more superficial level, right? So if it's more genetic level,
That's the
it could be exactly. So it could be that carcinogen can actually affect the oncogene, it can affect the tumor suppressor gene, it can affect the gene that causes apoptosis, or it can affect the gene that regulates the interactions, right? So that carcinogen, so now if that carcinogen affected an oncogene, what happens is the oncogene, rather than being low in numbers and being inactive, can get activated. If an oncogene gets activated, that causes the tumor to form, right? Basically, it's causing more cells to undergo changes, and then they start replicating, and then they start multiplying. When they start multiplying, and they're not dying as fast as they're being made, so that means they're evading that apoptosis, right?
So they're activating for this one.
Huh?
Activating.
Yeah, so oncogene has to be activated. Tumor suppressor gene has to be suppressed. If an oncogene is suppressed, then there's no tumor, right? If a tumor suppressor gene is activated, it's causing the tumor, it's preventing the tumor to form, right? So this has to be suppressed. So in order for a tumor to form, this has to be suppressed and this has to be activated. And this one has to be a gene that regulates apoptosis. This has to be suppressed also, right? Because if a gene that's causing a cell to die is not activated and it's suppressed, what happens to the cell? No, it grows, right?
Wait,
So you have a gene, and that gene, its function is to cause the cells to die. Okay? So if that gene is working the way it's supposed to, what happens to the cells?
they'll die.
Dies, right? So, but if you suppress this gene, that means you make it inactive, right?
Which is not going to die.
Exactly, yeah. So cells are not going to die. You said the other way around. So the cells won't die, and then they'll multiply.
What is that? Which one is that?
So genes that regulate apoptosis have to be suppressed.
It's
or
not going to
inactive.
die. It's going to be active.
Yep, exactly. So that makes the cells active, and then they keep multiplying. And genes that regulate the interaction between tumor cell and host cell, obviously, depending on what kind of, so they can have two functions. Either they can enhance recognition of tumor cells by the human immune system, or they can inhibit. So if it's a gene that enhances recognition, you want that to be active for the tumor not to grow, right? If it's a gene that inhibits recognition, you want that to be inactive. Inactive, exactly. Because if this becomes active, that means the body is thinking, oh, this is just my own normal cell, it's not a tumor cell, and it's going to keep evading that immune system. Does that make sense? It's a very complex topic, unfortunately, and we have literally 5 minutes to explain this in our curriculum. So this is, but you just have to get a basic idea about it. Like there's a lot of things that go on in the background, with these genes, mutations and stuff. It's not as, we're just trying to simplify this.
By myself first, one more time study. If I don't understand again,
Come back.
okay, I'll
Try next time.
Sorry.
So it's basically what you have to see is are the genes activated or inactivated, and which genes have to be be activated for the tumor to grow, which genes have to be inactivated for the tumor to grow.
High score.
Right?
You got the high score.
So think about it yourself. An oncogene, does it have to be
Yeah, well,
activated
I
for the
believe
tumor to
it.
grow?
I got 27.
You're
An
number
oncogene?
3.
Yes, right? It's an oncogene. It causes cancer. So you want that to be activated for the tumor to grow. How about a tumor suppressor gene?
I got 20. I got
That has to be inactivated for the tumor to grow. Otherwise, if it functions the way it's supposed to function normally, it's going to suppress the tumor. So you want that for a tumor to form, this has to be suppressed. Okay? How about genes that regulate apoptosis?
Okay, yours.
Does it have to be activated or suppressed?
I just do.
Wait, hold on. I think so.
I didn't have time.
So if it's suppressed,
Don't suppress.
if it suppresses, the tumor grows. Right? Because they're not dying. If it's activated, the tumor won't grow. Okay, yeah, so we're talking. So we are talking about things that need to
I know
happen
that I
for
have
a tumor
to
to grow.
do that.
An oncogene has to be activated. The tumor suppressor gene has to be activated, and then you have the genes that regulate apoptosis that have to be suppressed, right? And then genes that regulate the interaction depending on what activity or function that they have. If it's an inhibitor gene, you want that to be increased, right? It has to be activated, the inhibitor gene, for the tumor to grow. But if it's an enhancing gene, you want that to be decreased for the tumor to grow. Exactly. Does that make sense?
Now I wrote it, so I will have to remember to try to.
Yeah.
Professor, we just checked, and the oral path from your side, like your section, will be Friday.
I'm sorry?
It will be Friday, the exam.
What exam?
The oral pathology section.
Oh, section exam?
Yes, it's Friday. And we have, Thursday we have farm, which is our hardest class too.
Okay.
So I don't know if we can
You will want your the president of your class send an email to Dr. Richards. She's out of the country this week, but if you send her an email, then she's aware of that because she's the course director. And then you can decide at that point how it can be changed, or can it be changed? We don't know. So, but ask your class representative to send her an email with the concerns that you guys have for the section exam.
Thank you.
No problem.
What about the section?
I think for the school you have to make it one time.
Okay, guys.
I'm like, I have
We'll
to
go ahead, get started. Okay, we'll go ahead, get started with the oral path topic. So we're going to talk about soft tissue lesions, okay? And this is important for you guys, this topic, is because this is something that you'll end up seeing in your clinical practice quite a bit, okay? So soft tissue lesions, pay attention to this because this is pretty much the bread and butter of, the mucosal lesions that you see in patients. It's very common to see these entities, okay? So when we talk about different soft tissue lesions, it's important to know if they are reactive lesions or if they are true tumors. Okay, so you guys need to know the difference between something that's reactive versus something that's a true neoplasm or a tumor. Okay, so when I say reactive, what does that mean to you guys? What do you think is the underlying mechanism that's causing this lesion? Irritation, right? So basically you have some kind of localized irritation or trauma or something that's potentially is leading to that, lump to form, okay? So that's a reactive lesion. So irritation fibroma is the most common lesion that you will see in the oral cavity, okay? So the other name for it is called focal fibrous hyperplasia, and that's basically based on histology, okay? So if you took a biopsy of an irritation fibroma, looked under the microscope, it's going to have lots of fibrous tissue, okay? I mean, it's focal, it's localized, right? So it's a focal fibrous hyperplasia. What does hyperplasia mean? Increase in cell what? Number, right? So there's increase in the number of cells. So there's increase in collagen production here, right? So the fibrous connective tissue. So that's why you have focal fibrous hyperplasia. So it's a reactive lesion. You have to have a source of irritation or trauma in order to make this diagnosis. Yes?
So that'd be an increase in fibroblasts or just fibroblastic activity?
So typically there's, it depends.
Okay.
So majority of the times you have increase in fibroblastic activity, and that leads to increased fibrous tissue formation. Okay, so that kind of correlates to seeing, increase in number of fibroblasts. So it kind of goes hand in hand, So it's a reactive lesion, it's a hyperplastic lesion, and you have to have a source of irritation or trauma. This is not a true tumor. Okay, so please don't call fibromas tumors. They are not neoplasms or tumors. They're just reactive lesions. So how do we see them? This is something you'll see in patient's mouth, and it's extremely common to see this. Okay, it is, as I said, one of the most common entities that you see in the oral cavity. What do we see here? Can someone describe this for me? Other than that, we're pinching it significantly. So. Okay, so let's start with location. Buccal mucosa, right or left?
Right.
Right, okay. Patient's right. Okay, so where do we see on the buccal mucosa? Is it anterior, posterior? Anterior mid buccal mucosa, right? Is it at the level of the occlusal plane? Yes, so it's where the top and bottom teeth meet. Okay, so now describe the lesion. Is it a single lesion?
Yes.
Does it have a smooth surface?
Yes.
Yes. What is the color? Pink, right? So it looks like, it is pretty much the same color as the adjacent mucosa, maybe a little bit of redness to it, but for the most part it's pink, okay? Is it well defined?
Yes.
Yes. So this is a solitary, well-defined, nodule that you're seeing on the buccal mucosa on the right side at the level of the occlusal plane, right? In the mid-buccal mucosa, okay, with an intact surface. So that's how you describe it in your descriptions, right? So when you see that, what is it that, then you have to always think of, if you see it on buccal mucosa at the level of the occlusal plane, the first thing you have to consider in your differential diagnosis is irritation fibroma. There's many things in the mouth that can mimic a fibroma, but the first thing you have to consider on top of your differential is irritation fibroma. So if I gave you this picture in a quiz or an exam and ask you what is going to be on the top of your differential diagnosis, what would you tell me? Irritation fibroma. Please don't call it lipoma. Please don't call it neurofibroma or schwannoma, because they're all good answers, but that's not the most common ones. Okay, most common is fibroma. Okay, and this is typically how they would present, is that, single lesion with an intact mucosal surface and at the level of the occlusal plane. This is more common in adults. This tends to be more common in women, and this is the most common site. But any site in the mouth where there's a potential for someone to traumatize themselves or have, a source of irritation, you can see a fibroma. Okay, but the most common site tends to be usually buccal mucosa. So these are just different examples from your textbook, and you can see that there's a variation in color, right? So if you see here, what's the color of this lesion?
Black.
So it almost has this, exactly like a darker pigmentation to it, right? And that's because this patient has natural pigmentation in the mouth. So the lesion actually appears more pigmented than, someone with this. It doesn't matter, right? Even if you see this with pigmentation, it's still a fibroma, but it's pigmented. Okay, so and then here you can see there's a focal ulcer on top, right? But it's still a fibroma. It's in the right location, right presentation, so it's still a fibroma. How about these? Again, same thing, right? It's a single lesion. It's very well defined. It has a nice smooth surface to it. It's not ulcerated. It's the same color as the adjacent mucosa. It has all the features of a fibroma, but it's just that it's on the tongue. And this is a site of the tongue that can easily get traumatized. Okay, this is not very common on the gingiva. Okay, so to see fibromas on the gingiva is a little rare, and I'll talk about a few entities going forward. There's 3 entities that you always have to consider in your differential diagnosis when you see a mass on the gingiva in the interdental papilla area between 2 teeth. So you have one tooth and another tooth, and you have gingiva in between. Okay, that's the interdental papilla area. If you see a well-defined mass in that area between 2 teeth, there are 3 entities that start with the letter P, okay, that you have to consider in your differential. Apart from those, you can also consider a fibroma in your differential. Okay, so these are called gingival fibromas or peripheral fibromas that you can, yes.
So you said these mostly happen where trauma can happen.
What type of trauma, like chemical?
No, so trauma usually indicates that it's physical. Okay, so when we're saying trauma or irritation, basically we're saying it's a physical trauma. Okay, so that means the patient is biting on the cheek, for example, right? And if they constantly bite that part of the cheek, it can cause this tissue to grow in that area. Okay, or if they had like a motor vehicle accident, for example, and then you can have, and they accidentally bit themselves, or patient with seizures, for example. If they had an episode of seizure, and if they accidentally bit themselves on the inside of their cheek, the inside of their lips, that can again lead to, this tissue to overgrow. It doesn't happen with every episode of trauma, but sometimes, that's the way the body is responding it, right? Here, a lot of times the reason you see this is because of calculus in that area. Actually acts as a local irritant and then causes the excess tissue to form, okay, this fibrous tissue. So that's the local irritant. So if you do see that, what do we recommend to the patient? If you saw an irritation fibroma, what do you think is your recommendation going to be for treatment? Do you treat it?
Stop biting. Stop biting.
Okay, if the patient stops biting, is that going to shrink in size? No, it's going to look exactly the same. So you have to take it out. So if you see a lump in the mouth, if you saw what looked like morsicatio, if the patient stops biting, so that means it's just shredding of the tissue, then yes, it's going to resolve that problem. But once a lump gets formed, by then quitting a parafunctional habit, it's not going to do anything. That lump is still going to stay in the mouth, right? So your recommendation for the patient would be excision, right? So they do excisional biopsy, so that means you cut it at the base, and then whatever tissue is retrieved from the patient's mouth, you have to send it to pathology so it can be looked under the microscope, okay? So don't just tell them that, stop, chewing, come back in 2 weeks and it's going to go away. It doesn't go away. It'll still stay there, okay? So if you do a biopsy, what is it that we're going to see? You see, what is that top layer? It's epithelium, right? And what's this layer here? Your connective tissue. Does that look more pink? Right? So it's staining really pink here. And if you look closer, you can see it's really hyalinized, right? So that's all your fibrous connective tissue. And here it's actually forming like almost like a circular mass in the connective tissue. So this is where the fibroma is, the meat of the lesion. So that's all excess collagen that gets deposited and then forms this tissue. Okay. You don't need to memorize histology for that. Okay, that's just to show you what it looks like under the microscope. So your treatment is excision, and they rarely come back. As long as the surgeon goes and make sure that he makes an excision at the base of the lesion. So this is where they'll end up cutting it. Oops. So if you see here, so this is where the surgeon will basically take a scalpel and then they'll cut it right around this area. Okay, so what they'll do is they'll take some local anesthetic, infiltrate around the lesion, and then they'll take a scalpel blade and then just cut it right at the base. Because if you don't cut it at the base, it's going to come back. It's going to recur, right? So they have to make the excision at the base. Okay, so there's a type of fibrous hyperplasia. So one type is the fibroma, the irritation fibroma, which looks like a mass on the buccal mucosa, right? Or it can be seen on other sides. There's another type of fibrous hyperplasia that's called Fresnel tag. So what type of frenum is this? Labial frenum. It's a maxilla, right? So that's between 2 anteriors. So you have maxillary incisors, 8 and 9. So this is your labial frenum. And is this normal? No. So there's a little tag of tissue that you can see sometimes adjacent to the labial frenum. So that's called frenal tag, right? So if we cut this frenal tag out and then look under the microscope, it's basically just going to look like the irritation fibroma. So like that fibrous hyperplasia. But rather than forming a nodule, it just forms a little tag, like a skin tag. Okay? And that's the most common site that you see a frenal tag. If you see this, if it's not interfering with patient's function, right? So for example, if a patient wears an upper denture, okay, and the denture seats in, against the labial frenum, and if they have this frenal tag, sometimes that can cause ulcer in that area. So in a situation like that, you may have to recommend, removal. But if the patient has their teeth, this is not interfering with their function, you don't have to necessarily remove it, okay? But if it's an aesthetic concern, some patients, they have a high smile line, right? So when they smile, you can see pretty much all the way, up into their gingiva, right? So in something like that, they may want to get this removed just for aesthetics. So you have to take it, case by case. But ideally, you don't have to take it out if it's not bothersome. Okay, so that's one type of reactive lesion, okay? So there's another type of reactive lesion that's called epulis fissuratum, okay? So epulis is basically a generic term. So anytime you see a mass that grows on the gingiva or an alveolar ridge, you call it epulis, okay? So epulis fissuratum basically is something that is commonly seen in someone who wears dentures, okay? So if a patient uses a denture, and if they have an ill-fitting denture, so that means whether it's a complete denture or partial denture, you notice that it's not, seated appropriately. It's not fitting appropriately. What can happen is at the flange, so at the base of the denture, where it fits in the vestibule, it can cause excess tissue to form. Okay, because there's constantly movement, it's not fitting well, it can irritate the tissue in that area and cause this excess tissue to form. That tissue that gets formed is called epulis fissuratum. Okay, this is again a reactive lesion. This is not a tumor. So you have, in order to make a diagnosis of epulis fissuratum, you have to have a history of patient using an ill-fitting upper or lower denture, a complete or a partial denture. Okay, but they have to have usage of denture in their history in order to make this diagnosis. So what do you see here? Is this normal?
No.
Is this normal? Okay, so so this is a ridge, right?
Yeah.
Okay, so what's all this?
Growing.
Excess tissue, right? That's growing. So this is where your denture is going to sit, the patient's denture, right? So you'll have a lower denture. That's where the flange of the lower denture fits, right? So that's the bottom of the denture. So the area where the flange fits in the vestibule, if that denture is not a good fitting denture and there's constant movement, then it's going to traumatize the tissue at the base, okay? And then it causes this excess tissue to form. So if you took the patient's denture and you placed it, that's what you would see. So you have excess tissue that gets formed and it starts growing in that area to the point sometimes where it can actually overlap the denture. Okay? And so that's not fun. Yes?
Is that soft or hard tissue?
Soft. So when you palpate it, it's going to feel like a soft tissue, but it can be firm in consistency, but it's soft tissue. It's not bony hard. Okay? So, but that's when you see this, your diagnosis is going to be epulis fissuratum. Okay? So you don't make any other diagnosis when you see something like this. So in the right context, with the right history, this is what you would make a diagnosis of. So always check with the patient how many years they had the denture, what is the fit of the denture, then take that denture, put it in the patient's mouth and see if this mass that you're seeing, does it align with the flange of that denture. Okay, so if you see that, then this should be on the top of your differential, epulis fissuratum. So you can have a single fold, you can have multiple folds, again, depending on how that denture fits, right, when you have this growth. It's usually something you tend to see in adults, usually, middle-aged or older adults. because of the patient population that usually wears dentures is in that age group. They tend to have more a higher predilection for women, and it's usually, it's a firm consistency, but it's a softer lesion. Okay, so because it's all made up of fibrous tissue. So that's why if you look at the title, it's called inflammatory fibrous hyperplasia. So this is also a type of fibrous hyperplasia, like fibroma, like Fresnel tag, but this is associated with inflammation too. Okay, and has to have a denture in place. So irritation fibroma, Fresnel tag, Epulis fissuratum, they're all reactive lesions. They're not tumors. They're all fibrous hyperplasias, but Epulis fissuratum also has significant inflammation associated with it and use of dentures. Okay, so it tends to be more common on the facial side when you look at the vestibule rather than the lingual aspect or the palatal aspect, right? So most examples that you end up seeing tend to be more on the facial side. And it's more common in the anterior part of the jaw rather than the posterior jaw. Okay. So this is another example. Okay. So if you see here, what's going on here? How do you describe this? So this is it maxilla or mandible? Mandible. Okay. So where is the lesion? Is it on the facial aspect or the lingual aspect? Facial. So now what's going on the facial aspect of the alveolar ridge? Do you have one fold or multiple folds? Multiple folds of this hyperplastic tissue, right? But what else is unique about this? What else are you seeing in these folds of tissue? I'm sorry? It looks like it's ulcerating right in the center here. So there's like a linear ulcer. Okay? So it's like a line-like ulcer that's between the two folds. Okay? So sometimes patients with a condition called Crohn's disease can get similar lesions in the mouth. So always take a good history. If the patient's dentures are fitting well, if it seems like it's not related to the dentures, then you have to find out if they have an underlying systemic disease that's contributing to this growth. Okay, so sometimes it could be Crohn's disease that could do that. Occasionally, they can have significant ulceration like this, not just linear. But if you see the center of this, that's a deep ulcer that you're seeing there, right? On either side of the growth. So when you see something like that, what else should you be worried about? What kind of infection? Bacterial, viral, fungal?
Bacterial.
What kind of bacterial infection?
Here we go.
Let's see.
Come on, I want you to. Alright, let me know.
Okay, what are the more common ones that you guys know of that are bacterial infections? Huh? Streptococcus, okay. Where does streptococcus typically affect? The throat, tonsils and pharynx area, right? So tonsillitis and pharyngitis, so that's not that. Staph. No. Do you get staph infection? No. Usually tend to be more superficial skin infections, yes. Okay, so let's go for a little more common one.
P. gingivalis.
P. gingivalis. Where's the teeth here?
Candida.
Candida is bacterial?
No, it's fungal. I know it's fungal.
And does Candida cause deep ulcers in the mouth? No. Okay. More common bacterial infections that can cause non-healing ulcers are syphilis and TB. Okay. So those are two bacterial infections you have to worry about. Fungal infections, you can get it, but they tend to be deep fungal infections, not Candida. So like histoplasmosis, cryptococcosis, aspergillosis, millions of things. But you just need to know it's deep fungal infection. One thing I would be more worried about than all of those is malignancy, squamous cell carcinoma. If you have a patient that has an ulcer that's not healing and they have this kind of exophytic kind of growth surrounding it, and if you're not able to correlate it to a denture use, right? So if this patient tells you that I haven't worn dentures in 10 years, right? And you see this kind of a lesion, would you be worried about Epulis fissuratum? No, because there's no denture to actually cause trauma, to cause a reactive lesion, right? Then you're thinking more about squamous cell carcinoma. But if this patient has been a denture wearer and then they have an ill-fitting denture, that's the first thing you would think of then, epulis fissuratum. Then you go ahead, get a biopsy done, and if it comes back as epulis fissuratum, then you take the rest of it out. But if it comes back as a squamous cell carcinoma, then your treatment changes. Okay? So you have to think, depending on the context. Context is really important. So that's why do not memorize pictures, because there's many things that look exactly the same or at least very similar to each other. By memorizing pictures, you don't get a diagnosis, right? So you have to see in the context. You have to know what they're typically supposed to present as and what is the history that goes along with it. So epulis fissuratum, you always have to have a history of a denture use. You have to have that denture has to be an ill-fitting denture, right? Only then, if you see a tissue growth, then you can make that diagnosis of epulis fissuratum. If you didn't have that information, please do not jump to that diagnosis right away. Okay, you have to consider other things too. So look at these here, and these are from your textbook. They can be as excessive as this. Look at the amount of tissue growth that you have here. Okay, I just saw a patient, was it I think 2 weeks ago, and the OMFS resident was extremely concerned about it because it looked just like this. But then apart from that, what it also did was it was attached to the lip, on the undersurface of the lip. And he's never seen anything like that before. And but it's just epulis fissuratum, but just the amount of exuberant growth that the patient had, it was just masking the entire area. Okay, so I mean you have to go in surgically and excise everything out. Yes.
Is it painful?
They usually tend to be painful.
Right?
Yes.
But even the tissue?
Yeah, so when they're chewing and then doing activities, right, the denture is going to impinge on that, and then it's going to cause pain for the patients. And the more tissue grows, the more ill-fitting the denture gets, right? And then it's just like a vicious cycle, unfortunately. You had a question, and I'll come back to you. I'm sorry?
Can they speak like that kind of?
Can they speak?
Yeah.
They should be able to. It's just uncomfortable, but it shouldn't have an impact on their speech.
Why do they want to get the scars?
That's a $1 million question. There's a lot of things, unfortunately, patients walk around with tumors in their mouth or in the head and neck area, and you wonder how they let it get to that size. Yeah. Sometimes it's, I think a lot of times it's unfortunately lack of access to care, right? They don't have insurance. They just want to wait and see if it just goes away, right? And then unfortunately when it doesn't go away and it starts causing pain, they have to get it looked at, majority of the times it's, as unfortunate it's lack of access to care. And sometimes patients, there's maybe a tiny fraction of them that don't care. What happens, they just walk around with these things, but majority of the times it's, they don't have access. What else? Someone else had a question. You had a question.
That was it.
Okay. So, again, if you see here, another example, right? And this is from your textbook. You see how you have the denture, the flange of the denture, you have this excessive tissue growth. Okay? So if you see this kind of a presentation, you can for sure say, okay, this looks like it's epulis fissuratum. You tell the patient, okay, we're going to go ahead and get a biopsy for you. But once the biopsy is done, then, depending on what the diagnosis comes back as, the treatment is going to differ. Again, this is a very rare presentation. This is not something you typically see, right? On the lingual aspect, you tend to see more on the facial aspect, right? If you have something like that, this can impact speech, okay? Because there's no movement for the tongue here, right? So they'll have difficulty, pronouncing certain, using certain letters like S's and T's, they'll have difficulty. So they may lisp, so this can have an impact on the speech. If you did a biopsy, again, you don't need to memorize these histology slides. It's going to look just like it looks clinically. So you get these, multiple folds of tissue. And if you took a closer look of that, it's just all fibrous tissue, right? And then, but they also have inflammation here. You see these blue cells there? That's all inflammatory cells. So you have excess fibrous tissue combined with inflammation, right? So that's why it's inflammatory fibrous hyperplasia. So you not only remove this epulis fissuratum, but you have to make sure that the dentures get addressed, right? Because if you don't take care of the problem that's actually led to this, it's going to come back again. So either the dentures have to be relined or remade, but something has to be done to address that fit of the denture. Okay, don't ask them to wear the same denture again. Okay, there's another entity that can arise secondary to denture use, okay, which is also reactive. And this is called inflammatory papillary hyperplasia. So when you kind of dissect that name, if you say inflammatory, what kind of cells would you see? Like lymphocytes, it could be neutrophils, depending on acute or chronic inflammation, right? So if it's chronic, you tend to see more lymphocytes. If it's acute, more neutrophils, okay? These tend to be chronic diseases, so you tend to see more lymphocytes. Papillary, what does that mean? What are we talking about when I say papillary? It's the architecture, right? Rather than being a smooth surface, it tends to have a papillary kind of architecture to it. That means it's finger-like growth. So if I make a fist, and if you look at my knuckles right here, so you see how you get a projection and a bump, a projection and a bump and a depression. So this appearance is called papillary. When you get this up and down, like almost finger-like projections, right? So that's the papillary appearance, and it's hyperplasia, right? So there's excessive number of cells. Yes.
Which one is more common, this one or the other one?
Both of them.
Both of them.
Yeah. So it just depends on, sometimes they can have both together. So that's a possibility too. So again, what is this is also a reactive lesion, and it develops beneath the denture, okay? So it could be an ill-fitting denture, okay? It could be poor denture hygiene that's responsible for it. Or if someone wears dentures throughout the day, like a lot of times patients will tell you, oh, my spouse doesn't know that I wear a denture, right? Because they sleep with their denture, they never take it out, and they don't want to take it out, and that's a problem because like your shoes, your mouth also, when you wear a denture, the mouth needs breathing time, right? So we take off our shoes and give it rest. You have to do the same thing with the mouth, with the tissues, right? But they don't take it out, and unfortunately that's a breeding ground for candidiasis, okay? And then they get other lesions secondary to it, okay? But they do that. And sometimes they can be super infected with candida, these inflammatory papillary hyperplasia. So candida could play a role, the fungus. So what do we see? Yes?
The uncertain role.
Mm-hmm.
So candida, uncertain role. What do you
So basically, what it's trying to say is in IPH, or inflammatory papillary hyperplasia, the literature is not 100% certain about if candida itself can cause the disease process, or the patients have this disease because of an ill-fitting denture, but they have candidiasis associated with it. So we don't know if candida is a causative factor or if it's just an association with the disease process. That's why it's an uncertain role. Okay. So if you see this, what do you guys see here? So it's on the palate. Okay. What part of the palate? Hard palate. Okay. And then what is it, all over the palate, or is it just in the midline? Just in the midline. Okay. Is that a normal appearance of the palate? No. What's abnormal about it? Are they single or multiple bumps? Multiple nodules, right? That are clustered together. So this is that papillary appearance, right? So you have multiple pebble-like nodules or papillary, structures that you're seeing here, that are clustered together, okay? So this is what you would see in inflammatory papillary hyperplasia. If a denture is either ill-fitting, or patient sleeps with the dentures, doesn't take it out, wears it 24 hours a day, this is the appearance you would expect. The most common site to see inflammatory papillary hyperplasia is actually hard palate. It's not very common to see it affecting the mandibular alveolar ridge. It tends to be more common on the tissue surface of the upper denture, hard palate. Or it can be like this. Okay? What is different about this compared to the previous picture? And this is from your textbook. So it's more generalized, right? It's a wider area that's affected. Is that it?
You have a lot of purple.
It has a reddish hue to it, right? So there's a difference in color. So this reddish appearance that you're seeing here, that is called denture stomatitis. Okay? So if you didn't have these bumps, okay, and you just had this red appearance of the palate, we would just call it denture stomatitis, which is a type of Candida infection. Okay? But now you have this, you can't call it denture stomatitis. You have to call it inflammatory papillary hyperplasia with possible candidiasis, right? Infection. So there could be two things that are simultaneously happening at the same, in this patient. So you have to treat this patient with an antifungal, because if the Candida is the one that's responsible, then it'll basically get rid of the candidiasis, right? And then whatever lesions remain, at that point the surgeon has to make a decision: do they want to completely excise it or do they want to partially excise it? Okay, but that's a combination lesion. That's another example, again from your textbook, and you can see here those nodules. There are multiples of them. They're clustered together. They're like these pebbly nodules that you're seeing. Yes?
You said they're from dentures, but can you get them from ortho appliance? Unlikely, yeah. I'm not familiar with the retainers causing inflammatory papillary hyperplasia. Okay. So what do? You basically do the biopsy. When they do the biopsy, this is basically what you would see. Again, you don't have to, focus on histology here, but all you're seeing is these finger-like projections. You see how the top layer, the epithelium, it's not a smooth surface. Again, as I was showing, if you look at your fist and you look at the way your knuckles are, it just basically corresponds to the bumps, that you see on the fingers, right? So you get this elevation, depression, and that's what it looks like clinically too. Okay, and this is there's a significant amount of connective tissue that gets formed, and then the epithelium is hyperplastic, and they also have inflammation associated with it. So again, depending on what stage these are recognized, if it's a very early lesion, you ask the patient to take their dentures out, not sleep with them. You prescribe antifungals if you think that there's potential candidiasis associated with it. A lot of times what I would do is with patients that have this presentation, I'll give them a prescription for nystatin suspension. It's a liquid. They take 4 drops of that liquid and add it to a cup of water, and then add a denture cleanser like Polident, Effident, and then they'll soak their dentures in that solution overnight. And then the next morning they'll take it out and then scrape everything out with a toothbrush. So that'll basically get rid of any yeast infection in the denture itself. Okay? So not only are you treating the mouth, you also have to treat the denture. Because otherwise, the moment that they put the denture back in their mouth, it'll just come back, right? So it's not really going to address the problem if you don't treat it. If it's an advanced lesion, you have to excise the tissue. I don't know why it's doing this. Okay. Oops, that's not what I wanted. Okay, so again, you have to treat the dentures. Either you do a tissue conditioning, while they're undergoing, after they undergo surgery, for the interim period, and then once they heal, you can make new dentures for them. Okay. So the next 3 entities, I want you to learn it as a group. Okay, basically because they'll present very, very similar to each other. So usually, remember when I said the 3 P's, there are 3 diseases that start with the letter P. Okay, these are the ones. So anytime you see a mass on the gingiva, in the interdental papilla area, so that means on the gums between 2 teeth, okay, and if it's a lump that you're seeing, you have to consider these things in your differential. They're all reactive. So far, everything that we have talked about, they're all reactive lesions. They are not true tumors. Okay, and the reason why you see the 3 P's, pyogenic granuloma, peripheral giant cell granuloma, and peripheral ossifying fibroma. Okay, all the 3 P's is because patients have poor oral hygiene. Okay, so they have a ton of plaque and calculus that gets deposited around the teeth that basically acts as a precursor. It irritates the tissue, and then they have exuberant tissue growth in that area. Okay, they're reactive lesions, not true neoplasms. So what do we see here?
Not the diagnosis. You have to describe. It's in the anterior mandibular gingiva, okay? In the interdental papilla area, okay? It's red. It has a red surface to it. What else? Does it look lobulated or does it look smooth? Lobulated, right? So it looks like it has multiple lobules that are clustered together with lines separating them out, okay? Does it look hemorrhagic, like it's going to bleed? Yes, so it has a hemorrhagic surface to it, okay, and it's in the interdental papilla area. This is a pyogenic granuloma, okay, but then a peripheral giant cell granuloma and a peripheral ossifying fibroma and a fibroma that we looked at before, they can all present like that. So that's why you need a differential diagnosis, unless and until I give you histology. If I give you histology, you should be able to make a definitive diagnosis. But if I give you this picture, you need to be able to give me a differential diagnosis. You have to have at least 3 differentials, right? The 3 P's. So please memorize those 3 things that in your differential.
So in this case, they'd have to do a biopsy.
Yes. Yeah. Anytime you see something like this, you have to recommend that the patient get a biopsy. But then after you excise it, you also have to make sure that the patient gets localized scaling and root planing in that area. Because if you do not take the reactive irritant out, it's going to come back. And these recur. Okay, they all have a recurrence potential. Did you have a question? No. Okay. So, and this is more common in females. You can see pyogenic granuloma anywhere in the mouth, not just gingiva. Whereas the other 2, you don't see it anywhere else in the mouth. Okay. So out of the 3 P's, pyogenic granuloma is the only one that can be seen anywhere in the mouth. So you can see it on a tongue, you can see it on the lip, on the buccal mucosa, anywhere in the mouth, not just gingiva. Again, female predilection, they also tend to have association with pregnancy. Okay, so this is, you get this lesion in pregnant women. It starts off in the first trimester and then it gradually increases in size till they get to the 3rd trimester. Okay, once they get there, basically, if you see a patient, while they're pregnant and you see this lesion and you're suspecting it's a pyogenic granuloma, don't recommend that the patient gets taken out. Okay, you have to advise the patient to actually wait till the child is born. Okay, because what happens is once the hormones get stabilized, it actually regresses a lot of times. So it may not be the same size as what you had seen, during pregnancy, right? So once the child is delivered, then the patient comes back. If it doesn't regress, then you remove any residual lesion in that area. And you also have to do localized scaling and root planing. Okay, so it has a significant correlation to hormonal effects in the area. So that's why with during menstruation and during pregnancy, you'll see that these lesions have an increased potential to grow. And the name pyogenic granuloma is not a well thought out given name. Unfortunately, because this does not cause pus, this does not create pus. Pyogenic means pus producing, right? There's no pus that gets formed here. Granuloma means it forms a mass histologically that's made up of different kinds of cells. This does not form granuloma. So both, I'm not sure why they came up with this term, but it doesn't do either of those 2 things that the name suggests, unfortunately. Okay. And they bleed excessively, these lesions, because histologically, when you look at a pyogenic granuloma, they have a lot of blood vessels in them because it's granulation tissue. Right, so there's a lot of blood vessels. So these have a potential to bleed profusely when you excise them. Again, this is an example. Remember I said pyogenic granuloma can be seen anywhere in the mouth, not just gingiva. This is an example of pyogenic granuloma on the tongue. Okay, and if you look at the surface of it, it's ulcerated, right? That's a common theme that you would see with these. There's ulceration. This is a pyogenic granuloma in a pregnant patient. Okay, there's a term that you use to describe it. It's called granuloma gravidarum. You don't have to memorize that. As long as you say it's pyogenic granuloma of pregnancy, that's good enough in your exams and quizzes, right? If the history tells you that this is a pregnant patient.
So we have to say that in order to get right.
Yes, in order to get full credit, please say pyogenic granuloma of pregnancy if the history suggests that it's a pregnant patient. Okay, so again, by just looking at it, it's hard to tell, right? You just have this exophytic tissue growth in the interdental papilla area growing, covering the teeth. So you have to wait till the patient delivers the child and then see what it looks like before you take it out. Sometimes you can get pyogenic granulomas growing out of extraction sockets. Okay, so this is called epulis granulomatosa. There's a specific diagnostic term that's used to describe this process. It's called epulis granulomatosa. You have to memorize that name. It's basically a pyogenic granuloma that grows out of an extraction socket. Okay, so if a patient comes to you and tells you my socket is not healing, after the tooth was taken out, then you want to start exploring and seeing if there's some excess tissue growth in that area. If there is, you have to make sure that the patient gets a biopsy done and then, make sure a diagnosis is established if it's pyogenic granuloma. Occasionally, you can have squamous cell carcinomas arising in these areas, and they also prevent an extraction socket from healing. Okay, so if you have a patient who complains that they got a tooth taken out maybe a month ago, but it has never really closed, and or they have tissue growing out of that area, you have to make sure that you get an x-ray done, right? And then make sure that the patient gets a biopsy done to figure out if it's just a pyogenic granuloma or if it's squamous cell carcinoma. So histologically, you're going to see lots of blood vessels. Focus on histology for this entity and the other two P's, okay? Because that's the only way you can differentiate them. The difference is the blood vessels. So pyogenic granuloma, it's a lot of granulation tissue. So you'll see all these blood vessels. These are all blood vessels mixed with inflammatory cells. Okay? So that's why they bleed profusely and they look hemorrhagic. How do you treat it? You have to excise them. You have to make sure that when the surgeon, excises it, that they go down all the way to the periosteum, not just excision on the top. They have to go down to the bone level when they take it out. And then they have to follow it by scaling and root planing. If that's not done, these are going to come back. And the recurrence rate is anywhere from 3 to 15%. Okay? I'll just show you two pictures and then we'll stop. So this is a patient with a pyogenic granuloma. Okay, and this is a profile view, and you can see how it's covering the the teeth, and that's what they do. Is you have to excise that mass all the way down to the bone level, to the periosteum, followed by scaling and root planing. If that's not done, these will come back. Okay, do you guys have any questions? Because we'll do the other two P's, and then kind of go over pyogenic granuloma again on Wednesday's class. Okay. Any questions?
For this specific one we just talked about, sorry if my breath's okay. There's these two here, so this one has to do with pregnancy and that one has to do with extraction. So is this the word that is needed?
No, as long as you say pyogenic granuloma of pregnancy, I'm okay. But you have to say pyogenic granuloma pregnancy. You need to have those three words in your answer.
That's why you're saying you don't need to memorize that
This one,
You need to say it like that.
Yeah. Sometimes this can get a bit tricky to memorize. So gravida means basically is pregnancy. That's what it is. But that's the obstetric terminology for it. So let's say gravida, and then para means, is it para 1, para 2 means is it first pregnancy, second pregnancy. So they have rules that they use.
So thank goodness we don't have
You don't have to memorize that.
Okay.
No.
When you're referring to histology, so on our quizzes, we're gonna have some histology on there.
The ones that I said you need to do, you should, like for example, pyogenic granuloma, you should know the histology, the basic histology, because that's the only way you can differentiate. Yeah, so you have a picture like that, so you need to recognize if you have a histology picture that has lots of blood.